So we warmly welcome all our colleagues who joined us today. On behalf of the European Renal Association Young Nephrologist Platform, it is a great honor and also my pleasure to open the second ERA JSN YNP joint meeting here. So not to make my words too long, let me just remember briefly that one of the main goals of ERA and JSN YNPs by initiating this event last year was to exchange our international experiences through an informal online discussion on hot topics of nephrology. So we are gratefully thank you for the endorsement of the European Renal Association and the Japanese Society of Nephrology Councils. Dr. Mio Murashima and Dr. Amaryllis von Kranenbroek will guide us through today's webinar, where we will hear presentations, talks on basic research and clinical topics on COVID and then renal transplantation. So welcome all our panelists and presenters here today. Thank you very much for being with us during this webinar. So I wish you a useful professional pastime in the next 2 hours. And I'm now giving the floor to Motoko Yanagita to open up the joint webinar. Thank you very much.
Thank you very much also, for your great and kind and warm greetings from ERA. And on behalf of JSN, hello everyone, and good morning for Europe and good evening for Japan. My name is Motoko Yanagita from JSN. I'm very pleased to join the second YNP-JSN joint meeting, and I'd like to express my sincere respect and gratitude to those who prepared this meeting. ERA and JSN have been collaborating since our agreement in 2015, and this exchange has been growing stronger every year. It is important to have a cross multi-generational exchanges in order to further continue this collaboration. I am confident that the YNP and JSN members gathered here today are the ones who will lead the next generation of ERA and JSN. I'm convinced that this exchange among the younger generation will serve as an engine to promote continuous and progressive exchanges between two societies. Nephrology in Europe and Japan has both similarities and differences. I believe that by learning from each other and exchanging our wisdom, we can achieve a better nephrology together. The program for today's meeting has been prepared very well, and I'm very much looking forward to it. I hope that the discussion at the meeting will lead to further collaboration. So I'd like to hand over to the message to young nephrology scientists from JSN and ERA. So Professor, please.
So thank you, Motoko. I'm taking over. My name is Christoph Wanne. I'm the president of European Renal Association. You can hear the name, you can see the name of Ivan Rychlik now. And we just changed the role, and he will do the closure of the meeting. Ivan Rychlik is our secretary treasurer of the association. So thank you, Motoko, for your kind words. And indeed, it is a long-standing collaboration we have with the Japanese Society of Nephrology starting in 2015. And we live this collaboration indeed, and we had face-to-face meetings at our annual meetings, ERA meetings, and also at the Japanese Society Nephrology meetings, and I remember a number of meetings I always attended. Now we expanded this collaboration now to the younger generation, to nephrologists, and this is our second meeting, and really appreciate the exchange of science and the enthusiasm of the younger people. And everybody, when we ask them, are saying, oh yes, I would like to come to this meeting, and maybe in the future again face-to-face. As I agreed as you know, to come already this year to the Japanese Society of Nephrology in June, before we have the ERA meeting, and deepen our collaboration and friendship. So also we have the closure of current President Masao Nangaku. We, Naoki Kashihara, the president, the past president, we had a lot of good moments and exchanges over the past years. And I thank you that you give us also your word for the opening, and I handle over to you, Naoki, please.
Okay, thank you very much, Christoph. I would good morning and good afternoon, everybody. So first of all, I would like to express our deepest gratitude to all those involved in both societies for the successful organization of this second ERA JSN joint meeting in 2023. So in particular, I would like to thank Professor Chris Vanna and Professor Masaomi Nangaku. Their strong, long-standing leadership and deep understanding made this meeting possible. The two societies, as Chris introduced, have a very long history of warm cooperations. This cooperation and friendship has led to great achievement in the kidney science and healthcare, and has made a great contribution to nephrology in the world. Although the world is going through a difficult time, and in order to keep this friendship strong in the future too, it is necessary for the younger members of both societies to get to know each other. The future possibility depend solely upon on the cooperation of these young kidney scientists. So I do sincerely hope this joint meeting will continue for a long time ahead. Thank you very much.
Miho Murashima from Nagoya City University, and it's my pleasure to chair this session, and thank you for inviting me. And I'm going to chair with Dr. Van Krenbroek. And can you introduce yourself briefly?
Of course, my name is Marlies van Kranenbroek. I'm a nephrologist in Belgium, and I'm the current chair of the Young Nephrologist platform. I'm very happy to be in this session and to learn from you and to have this beautiful interaction.
So let me introduce our first speaker, Professor Tobias Harber. And Professor Harber graduated from University of Freiburg, Vienna, trained in nephrology in the University of Medical Center Freiburg, and he's currently a director and professor of the Department of Medicine, University Medical Center, Hamburg, in Eppendorf, Hamburg, Germany. And within the last 10 years, Professor Harber and his team have identified novel concepts in kidney biology. Specifically, his work identified signaling programs that regulates podocyte cell survival and cytosis, cytoskeletal organization, and polarity, providing novel insight of how podocytes contribute to glomerular diseases. And today he's going to give us a talk on mechanism of kidney damage in COVID-19. Professor Harber, please.
Chairs, dear presidents and immediate past presidents, dear colleagues, dear young nephrologists, thank you very much for the kind introduction. Thank you very much for the invitation. It's really a great honor and pleasure and fun being here. Also, thank you for still considering me for the Young Nephrology platform. The two societies, JSN and ERA, are really world-class and leading kidney societies internationally. So it's wonderful to see them joining together for such an event. I've been asked to talk about the mechanism of kidney damage in COVID-19. Please recognize my disclosures. And while we start talking about COVID-19, we should also scientifically disclose that we are right now leaving the pandemic behind. So since the initial studies, there have been lots of evolution along the virus. There's been lots of adaptive mechanisms and immunity by the host, by us, lots of developments in terms of vaccines and new treatments. And we should keep in mind when I will be talking about the basic mechanisms that most of these restarts were gained in the initial phases of this pandemic, when we had a very high morbidity and mortality, many people in our hospitals, when unfortunately many of our patients died and we had access to tissue that we analyzed. For that reason, I think it's important to keep in mind that with SARS-CoV-2 changing now to a more respiratory-like, influenza-like virus, that the mechanisms that we talk about were done on these earlier phases and earlier variants of the virus, and that this now applies, fortunately, only to less and less patients, number one. Number two, we should see SARS-CoV-2 as a model for future challenges. And this is the young nephrology community here. So really, the next emerging infection pandemic will come, will appear. So we can use SARS-CoV-2 as a model to learn on emerging infections, to learn on organ and renal tropism, something that was very little known before SARS-CoV-2, to learn about the virus tissue interaction, specifically in the kidney, and also learn about long-term consequences of renal tissue injury. Now, again, also from a perspective also of clinicians and everybody who's on the path of becoming a clinician scientist, most of our research starts by clinical observations and by epidemiology. And the clinical observation at the beginning of the corona pandemic was that there was a very broad range of symptoms affecting all organ systems. And we quickly learned at the beginning of the pandemic that kidneys are being among the main targets. So we saw many patients on hospital admission with AKI or even severe AKI at the intensive care units. And the epidemiology was suggesting towards that the AKI in SARS-CoV-2 induced sepsis or intensive care units was much higher than for other reasons. And also the rate of renal replacement therapy required for these patients were much higher. And then now by starting looking back on the pandemic, looking like in this US study on looking at almost 2 million from the Veterans Hospital, we also recognize that people who were non-hospitalized, they have a very small decline in GFR. We don't know how significant this is, but when people were hospitalized, it is significant. And people that were hospitalized and suffered from AKI during hospitalization, there's quite a significant loss of renal function. Now, this is a very recent study by the ERA journal NDT from our team, being led by Christian Schmidt-Lauber. And here we looked at the Hamburg City cohort on mild COVID cases that were not admitted to the hospital. And we looked very careful with match controls for the impact of renal function. Like the large US study, we saw a small decline in GFR, but we didn't see any signs regarding proteinuria, regarding kidney injury markers or hematuria or any other signs. So from our cohort and follow-up, there were no warning signals in terms of mild cases. And this is something that applies, of course, now to larger populations being affected by the Omicron variant. Now, summarizing this first part, and it's by a wonderful review by Annette Bruchfeld. So basically what from a perspective of nephrology, we saw with the COVID crisis that kidneys were involved. We saw renal dysfunction. We saw highly increased rates of acute kidney injury. We detected that renal risk populations had high and extensive morbidity and mortality rates up to 20%. And we ask ourselves, will there be long-term sequelae consequences of the infections. So first part now, talking about SARS-CoV-2 renal tropism. So we hypothesized right at the beginning of the crisis, because of the observation of a broad spectrum of symptoms, that there might be an organ tropism, including the kidney. And we assembled a large team, and I apologize to those who will not be named, but in fact, it were over 7 institutions and departments at our hospital. It were over 35 authors on these different papers that I'm now going to show. And these were the leading scientists on many of these programs: Victor Puelles for basically all of the programs, Fabian Braun from the renal tropism, Nicola Wanner for the liver tropism, Maya Lindenmeyer for the biobanking, Christian Schmidt-Lauber for the epidemiology, and Francesca Solagna for the connection of kidney fibrosis and muscle function. Now, first observation, right at the beginning of the crisis, and at the time it was one of the largest published autopsy studies of 28 cases, here shown 22 cases, and we came up with a tissue PCR to detect SARS-CoV-2 with tissue, and to our surprise, it was not only detected in these autopsy cases in lungs and pharynx, but also followed by high levels in kidney, liver, and heart. So therefore, nephrology made the claim that SARS-CoV-2 has an organ tropism and a renal tropism, and then by single cell analysis, we could associate this tropism with the expression of receptors for SARS-CoV-2, namely ACE2, and we came up with staining protocols to detect it, as seen here in the tubal system. Now, second study, shortly after, again, at the time of its appearance, one of the worldwide largest autopsy studies, now 63 cases. Here we wanted to go one step further, not just showing tropism and renal tropism, but showing that the virus is actively infecting kidney cells, number one, and number two, that we could retrieve from kidney tissue virus that kept the capability of replication. So really replication active virus in renal tissue. And then this was associated with a much higher rate of severe AKI during the lifetime of these patients. Now, based on these insights, Oliver Gross from Göttingen, a collaborator of us, came up with the idea saying, if the kidney is a target, then we might use this as an early seismograph detector for later outcome. And based on a very, very simple schematic, we basically used at hospital admission just simple urinary analysis. And if there were signs of proteinuria, albuminuria, or other signs of kidney injury, we tried to make an association of the urinary status at hospital admission towards the outcome. And there was a strong correlation actually from urinary abnormalities at admission to outcome. And for this reason, the urinary testing was included in the German guidelines for all hospitalized COVID patients at the time. Again, we are talking about March, April of 2020. Now, the next question was really now, what are, more molecularly speaking, the consequences in the tissue? And this was a next study that we then did, led by Nicola Wanner. And here we observed that similar to the kidney, in 2/3 of the patients admitted to our hospital, we detected increased liver values. And then we were building up different cohorts, one validation cohort in Michigan, United States, by Salem Hayek. And we also had an autopsy cohort so that we could now correlate liver clinics at admission, outcome, but also tissue analysis based on our autopsy cohort. And what we could see here in a large autopsy cohort was that liver hepatocytes as well as Kupffer cells and other cells are getting directly infected by SARS-CoV-2, number one. And number two, again, like shown before, we could retrieve active virus that could infect other cells again out of the liver. So this is basically the Koch-Schlechter postulate that the virus is directly infecting the tissue. Now, if you look at this, when we then compared livers that were infected from livers that were not infected from people who died due to severe COVID-19, we could see that the livers that were infected by the virus had very different signatures from livers that were not infected by the virus, mainly, of course, on the interferon response. And now going further to understand the molecular programs, and we analyzed the transcription factor activity, and we used in silico data from other hepatotropic viruses like hepatitis, and also HCV, HBV, and also HIV infections. And we compared the overlapping molecular signatures and then also included transcription factor analysis. And it turned out that the transcription factor profile in these SARS-CoV-2 infected livers were quite similar, as shown here, to livers that have had an infection with low replication hepatitis C virus. So this was an interesting finding, and we also detected other programs. This was the News and Views accompanying by Ellie Barnes, coming up with a nice model that via the respiratory tract viruses get into the gut, and from there via the portal system they are infecting the liver. And this was a little fun fact for our team that the paper retrospectively was announced the All Matrix #1 paper of the year of Nature Metabolism. Now, similar to the liver, there were studies, as here a study led by our collaboration partner Raphael Kramann in Aachen and his team, showing that SARS-CoV-2 infects kidney organoids and also induces molecular programs, including fibrosis. And this was a study published by the team of Joseph Penninger, and he could use also kidney organoids, showing that SARS-CoV-2 directly infects the tissue, and that this infection is being modulated by the metabolic environment, and diabetic environment leads to an upregulation of ACE2, the receptors for virus entry. Now I'm summarizing this part here. So basically, nephrology identified the multitropism of SARS-CoV-2, showing the power of nephrology in organ analysis in kidneys and beyond. We never claimed that this is the main driver of AKI. This is important. Sometimes it was interpreted as such. The main driver of severe AKI were the sepsis, the cytokines, the hemodynamic, and the procoagulant status, while the virus infection was a modulator at maximum, but not the driver. This is important. I think this was a nice summary and review article showing the 7 factors leading to severe kidney damage in severely COVID-infected patients, with the hemodynamic factors and cytokines and volume factors, the procoagulant status in SARS-CoV-2, and then 1 out of these 7 factors, eventual direct viral toxicity, and the programs that we discovered. Now, as the pandemic moved on, more and more we considered there's millions and millions of people haven't been infected across the world. What will be potential long-term consequences? So this is something that we got more and more interested in based on our very simplified model. Yes, the virus can infect the tissue. There's no more question about this, but what is really the role? What are the programs that might play a role in terms of long-term consequences? And this is unpublished work, again, being led by Victor Puelles and also Ali Eturk, our collaboration partner from Munich. Now, looking at human kidneys and primate kidneys, here optically cleared, and then we can visualize SARS-CoV-2 infection as it happens to these tissues. And based on this visualization, we are able now to go for laser microdissection and targeted proteomics of the regions that are directly infected and the neighboring region. And this is tissue analysis that are possible these days. So then we can see that the infected tissue carries all the signature of tissue infection and the immediate response. But interesting, in the neighboring tissue, we see molecular programs being instructed by the infected tissue, namely tissue fibrosis. So this leads to a new model, but again, remember, only for severely infected patients and only for a few patients where virus is spreading across the organs. But this model is, yes, the organ is infected. This instructs also the adjacent kidney tissue and might promote programs like fibrosis. And this brings me to the last part. So what it might be the consequence of fibrosis? To look at the consequence of fibrosis, again, another study out of our team led by Francesca Solagna. We looked in deep sequencing on factors that a kidney secretes when a kidney is fibrosing, and they identified a strong upregulation of procachectic factors. Remember clinical observation, every patient with advanced CKD suffers from muscle cachexia and frailty. And this is because the kidney specifically secretes and upregulates massively procachectic muscle factors, namely activin alpha. And then these days we can do single cell analysis and identify the cells. We identified that these are fibroblasts, so CKD, more fibrosis. Certain fibroblast regions are proliferating, and they are the ones seeding the muscle procachectic factors. And we can interfere by trapping these circulating factors away, or by removing the receptor of these procachectic factors on the muscle, and then we can restore muscle metabolism and muscle homeostasis. This could be a potential treatment for all of our dialysis patients. I'm summarizing here. So nephrology is exciting. It has never been more exciting than these days. Nephrology uses and developed deep tissue analysis and organoid tools, allowing really to prepare ourselves for emerging pandemias as we saw before, and help nephrology to solve questions regarding SARS-CoV-2. The model is kidneys can be severely affected in severe COVID-19, as we see it now, fortunately, much more rarely and in much more selected patient groups than before. These are the main driving factors. The viral infection has just a modifying role. That's what we believe, and can play a role for long-term consequences after people who have been severely sick with COVID-19. And we learned from looking at these that there are interesting inter-organ programs being derived from kidney fibrosis leading to muscle cachexia. With that, I would like to thank, these are our just faculty, 24 faculty members, over 150 people who focused their research in our Hamburg Center for Kidney Health at the crisis on COVID-19, helping to, or trying to help to uncover some of the programs. And with that, I'm looking forward to questions.
Thank you, Dr. Harber. Is there any question from audience? So may I start?
Please.
So you said the kidney damage has been decreasing recently, and is it that because of the genetic mutation, or is it the effect of antiviral medications?
So
is there any insights from the basic?
Yeah, multiple factors. Number one, we see a strong evolution of a virus, which becomes less injurious to tissue as before, very clearly, and which on the other hand developed as immune escape mechanisms. So it transmits easier while it affects the humans less severely. So clear evolutionary trait, number one. Number two, the host is now prepared. Part of the initial crisis was a virus hitting an unprepared host. Now everybody has been infected. most of the people have been vaccinated multiple times. So the host situation is now totally different. So this is factor number 2. Now, and then factor number 3, for the few people that are getting severely sick, we have medications at hand that we use, for example, in our transplant community. If people come with more severe symptoms, I mean, these are the only people right now being admitted to the hospitals that we see are people who have other morbidities or are immunosuppressed, and we start treating them quite early with a few different medications, and by that also ameliorating the course of disease. So it really, the threat totally changed.
Thank you. Dr. Yanagita, please.
Okay, hi Toby, and thank you very much for the beautiful presentation. It was so impressive. And I found it very interesting that viral infection alters or reprogram proximal tubes. And do you think that already impaired proximal tubes are more susceptible to its reprogramming by viral infection?
Yeah, I think this is super interesting question. And I think this happens because we only see this in really, I mean, our analyses are based on autopsy tissue, people who died because they were so sick. And here the tubule is already injured by organismal factors, hemodynamic factors, and so on. And this might promote further than the pro-fibrotic and programs being eventually driven by the virus as well. Yes, I think this is an important factor. While we see it on healthy kidney organoids as well, but organoids in situ is still a different thing. So I think in situ, in vivo, this plays a role. Very good point.
Thank you very much.
And Amaryllis, please.
Yes, thank you very much, Professor Huber, for this for sharing this very interesting information with us. I'm a little bit puzzled, of course. We think about the tubular cells, but what's your take about the podocytes? Are they also involved in COVID-19?
So yeah, and you know, most of my life I've been a podocyte biologist. So of course we started looking at podocytes, and we saw that we also in the glomerular compartment we could detect SARS-CoV-2, and then you know that there had been these kind of immune-mediated glomerular diseases and podocytopathies, like an collapsing FSGS type, which was rarely seen. And to my understanding, this was mainly, it was SARS-CoV-2 induced, but it was an a broader immune response, or not due to SARS-CoV-2 infection of podocytes. So our evidence that the direct podocyte infection contributes a lot to this is not there. So I think here the effects and the glomerular disease is also the more common relapses that we observed in podocytopathies like membranous nephropathy and other diseases has been caused by the immune challenge of SARS-CoV-2. This would be, I guess, at least from my viewpoint, the most likely explanation, rather than a direct SARS-CoV-2 toxicity to the cells.
Okay, great, thank you. Just have another question while the audience is still thinking about their questions, apparently. I was also very intrigued by the activin alpha. In what extent do you think it's true for COVID, or can it be true for the whole CKD population? And if this is true, what would be your next step to target this as a therapeutic molecule?
So it's true for the whole CKD population. Yeah. So I didn't show all the data, but we used, so basically just intrigued by the thought of fibrosis, you know, and following on Motoko Yanagita's trade, looking at this for a long time, we thought, let's look more careful on what fibrosis causes on organism level. So we used many different CKD models, like cystic models even, Alport, glomerular models. We used interstitial fibrosis models. So we used a large scale of different models, and they were all the same. They were all the same. Fibrosis itself induces proliferation of certain fibroblasts subpopulations and they secrete these factors in a relatively high manner. So capturing these factors as we did it, or taking away at the muscle level the receptor, can reverse this mechanism. Now, since activin alpha, belongs to a large family of TGF-like factors, so this is if you take it away, then muscle starts growing. So this is not the level that would be suitable for intervening right now. So we look for more downstream targets also in the muscle.
Okay, very interesting.
But you're completely right. Yes, this is something where we need to think about interference.
And do you think that physical activity is also influencing those levels of activin alpha? Or?
I don't think so. Physical activity is something that we, us doing all our dialysis patients and advanced CKD patients, because it's very helpful, but it's not as successful as it would be if there wouldn't be so many procaryogenic factors around. So physical activity or nutritional status alone cannot reverse the muscle loss, because it's never alone overrides the procaryogenic drive and signals from the kidney.
I completely agree. Yes. Thank you. I think for the sake of time, we will have to move to the next speaker. If no questions, I don't see any questions from the floor. So no questions from the panel anymore? No, I don't think so. Okay, so thank you very much again, Professor Huber, and I hope to see you in real life in Milan this year. See you. So it's my pleasure to introduce Dr. Yuka Sugawara. I hope I pronounce it right. She's a Japanese nephrologist with a focus on clinical research and genomic research. She graduated from the University of Tokyo, the School of Medicine, and she serves on several committees of the Japanese Society of Nephrology. She was the winner of the Young Investigator Award of the 19th Asian Pacific Congress of Nephrology 2 years ago. Her recent work is on GWAS, on kidney-related traits in the Japanese CKD population, some genetic analysis of rare diseases, but now she will present as COVID-19 related work, and her title is How Japanese dialysis facilities responded to the COVID-19 pandemic. It would be very interesting for us in Europe to learn about your strategies. Thank you and welcome.
Thank you for the introduction, and thank you for providing me such a great opportunity to present here. My name is Yuka Sugawara from the University of Tokyo. Today's my theme is how Japanese dialysis facilities responded to the COVID-19 pandemic. First, I'd like to explain the background. As of January 2023, more than 3 years have passed since the discovery of COVID-19 at the end of 2019. However, the disease remains unconquered, and we are currently living with COVID-19. It still has a significant impact on the medical care. Japan has experienced 8 waves so far, and most recent has been in January to February 2023. And it has now settled down. Japan had had a total count of COVID-19 infected persons until the last September, but it has now simplified to include only the elderly, hospitalized cases, and pregnant women, and some cases with high risk of severe illness. Patients on hemodialysis might be at a higher risk of infection and death than the general population because they generally need to go to the clinic 3 times a week. They have long clinic stays and they cannot stay cooped up at home. So coping with and preventing the spread of COVID-19 during dialysis treatment is a very important clinical challenge and a serious social problem. Therefore, we conducted a nationwide questionnaire survey in hemodialysis facilities in 2020 and 2022 to investigate how dialysis facilities responded to the COVID-19 pandemic. Now I want to explain the methods. This survey was conducted in cooperation with 3 related association or societies, JADP, the Japanese Association of Dialysis Physicians, JSDT, the Japanese Society for Dialysis Therapy, and JSN, the Japanese Society of Nephrology. The survey was conducted among dialysis facilities in Japan belonging to the JADP and JSDT. A total number of target facilities were around 4,200. The actual questionnaires were mailed to the target facilities, and emails requesting responses were sent from JADP and JSDT. One person from each facility was asked to respond to the questionnaire as the representative of the facility. The questionnaire could be answered either by sending a fax or by filling out an online form. In Europe, fax machines are not often used anymore, but in Japan, they are still preferred. The questions on infection prevention measures were prepared using the infection prevention checklist made by JADP named Guidelines for Standard Hemodialysis Procedure and Prevention of Infection in Maintenance Hemodialysis Facilities, which is written in Japanese. This guideline is not intended to address COVID-19, but rather general infection control in dialysis practice. Now we move on to the results. The first survey conducted in 2020, the response period was set from October to November in 2020, here between the second and the third wave. Its response rate was 53%. In the follow-up survey conducted in 2022, the response period was set from October to November in 2022, here between 7th and 8th wave. Its response rate was 47%. In both surveys, responses were received from all prefectures of Japan. About characteristics of surveyed facilities. About half were clinics specialized in dialysis therapy, and the other half were hospitals with other departments. The average number of dialysis patients per week at each facility was around 100. This slide shows the varying rates of PPEs in initiating or terminating dialysis operation. Before pandemic, only in 88% of facilities, staff members wore masks in initiating or terminating dialysis operation, but the varying rate improved and it reached 100% in 2021, and it also sustained in 2022. As for disposable, non-permeable gowns or plastic aprons, only in 60% of facilities, staff members wore this item before pandemic, but the wearing rate improved as time goes, and it reached 78% in 2022. As for goggles and face shields, same trends can be seen, and in 2022, the wearing rate reached 89%. But even in 2022, there are some facilities where staff members do not wear these items. This slide shows the implementation status of some infection prevention measures, especially with high implementation rates over 95%. Question 1 asks if staff members with symptoms of infection are examined by a doctor before entering the dialysis room. Question 2 asks if patients are checked for their temperature and symptoms before entering the dialysis room. Question 3 asks if patients with suspected infection are observed and infection control is modified individually according to their conditions. This slide shows the implementation status of other infection prevention measures with relatively with relatively low implementation rates, and the items only surveyed in 2022. Question 4 asks if linens are changed after each patient or not. And before pandemic, only in 28% of facilities, this measure is implemented. And in 2022, the implementation rate improved to 52%. But it should be noted that this description written in blue, non-permeable bed mats are used and the dialysis environment is disinfected between each patient. This text was added only in the survey 2022. And question 5 asks if items that are frequently touched by patient and staff hands are wiped or disinfected several times a day, and its implementation rate was 90%. Question 6 and question 7 are asked only in the survey conducted in 2022. Question 6 asks if staff are instructed to refrain from talking when unmasked. And question 7 asks if patients are actively instructed to wear masks during dialysis. This measure is not recommended by guideline, but the implementation rates are very high, 98% and 99%. How about bed spacing? Japanese guideline recommends bed spacing more than 100 centimeters. But even in 2022, only 39% of facilities satisfied this criteria. And there are about 12% of facilities with bed spacing less than 70 centimeters in 2022. We also investigated the feasibility of 4 isolation measures: separation using private room, separation of space with adequate bed spacing and partitions, separation in time slots, different schedule from other patients, and separation of staff who do and who do not take care of COVID-19 cases. There are 36% of facilities that do not have private rooms. And as you know, vaccination is one of the most important prevention measures against COVID-19 infection. So we investigated the vaccination status of Japanese hemodialysis patients and also asked some questions regarding vaccination. Patients are actively encouraged to receive COVID-19 vaccination in 95% of facilities. The status of COVID-19 vaccination is being monitored in 84% of facilities. And about a half of facilities responded that in case of fever, isolation protocol will be changed depending on vaccination status. Here we can see the vaccination status of Japanese hemodialysis patients. A total of 1,620 facilities responded to questions regarding vaccination. These facilities are taking care of 164,095 patients in total. Vaccinated patients occupied the most, 97%, and only 2.8% of patients remained unvaccinated at the time of second survey. We also asked the facilities why COVID-19 unvaccinated persons have not been vaccinated. 92% of facilities answered that they experienced the patient does not wish to be vaccinated. And a small number, of course, but there was 1% of facilities that answered they do not recommend vaccination to patients. I don't know why. And patient who remained unvaccinated because of history of COVID-19 infection or difficulty in vaccination due to allergic or background diseases. And 70% of facilities responded that patients are left to their own decision regarding vaccination, so they don't know why. Now we can see the COVID-19 infection rate and mortality rate associated with vaccination status. In vaccinated group, COVID-19 infection occurred in 9.2% of patients, while in unvaccinated group, COVID-19 infection occurred as many as 41% of the patients. And in in vaccinated group, COVID-19 related deaths occurred only in 0.3% of the patients, while it was 6.6% of the patients. And even we set the number of COVID-19 infection as a denominator of mortality rate, there was a significant difference between the two groups at 3.5% in vaccinated group and 16% in unvaccinated group. So we can summarize that Japanese vaccinated persons under hemodialysis therapy had lower infection rate and lower mortality rate compared to those who were not vaccinated. We also calculated the risk ratio. The risk ratio for COVID-19 infection in vaccinated group was 0.22, and the risk ratio for COVID-19 related deaths in vaccinated group was 0.05. Now I want to start the discussion part. For the infection control measures investigated in this study, implementation status was generally good. Many items on the checklist had a compliance rate of 95% or higher. But there still remain some items with low implementation rates. Question 4 regarding linen change had implementation rates of 52%, and wearing rate of disposable non-permeable gowns or plastic aprons was 78%. And I'd like to mention the land characteristics of Japan. Japan is a small country, and comparatively few facilities are built on large sites, so many facilities struggle to provide isolation using private rooms or spaces. To compensate for the lack of space, it may be necessary to implement other measures, such as separation in time slots, separation of staff, or transfer to facilities with adequate isolation space. However, this presents other challenges, such as increased cost and the need to coordinate with other facilities, which may be difficult for a single facility to handle. Vaccination coverage among Japanese dialysis patients was very high, approximately 97%. In hemodialysis patients, unvaccinated patients had higher infection rate and higher mortality rates than vaccinated patients, suggesting that vaccination is effective in preventing COVID-19 infection and COVID-19 related deaths. Similar results have been reported from other countries. The report from UK said that odds ratio for COVID-19 diagnosis in vaccinated patients was 0.21 or 0.27. And the report from US said that odds ratio for COVID-19 diagnosis in fully vaccinated patients was 0.40 or 0.67. Another report from Chile said that odds ratio for COVID-19 infection in unvaccinated patients was as many as 252, and the odds ratio for death in unvaccinated patients was 2.64. I should refer to the limitation of our study. The results are calculated from facility-level responses. This study did not collect patient-specific background factors, so we cannot rule out the possibility of other confounding factors between vaccinated and unvaccinated patients. A survey on vaccine efficacy in Japanese dialysis patients is scheduled to be conducted in this year to calculate odds ratios adjusted with background factors. I want to summarize today's talk. Japanese dialysis facilities had high implementation rates of infection prevention measures recommended by Japanese guideline. However, Japan is a small country and appeared to have difficulty with space-consuming isolation. Vaccines were considered effective in preventing COVID-19 infection and reducing COVID-19 related deaths. Thank you for listening.
Thank you for this beautiful presentation. I don't see any questions from the floor. If I may, I can ask the first question. I was very intrigued by some details of your presentation. And what do you think about the reporting bias in your study? So the reporting bias was 53% and 47%, the response rate. What do you think were the main reasons for not responding to the questionnaires?
Thank you for your important question. The response rate was about half, 50%. And we want to report this result first. So the response period was only 1 month. So probably it is one reason for the low response rate. And maybe some facilities not enthusiastic to infection prevention measures or maybe dropped from this study, so which may be a confounding factor for the result.
Okay. Do you think your results would have been different if you would have had a response rate of 100% or 90%?
Exactly, I don't know. I don't have a data, so I don't know. But
Okay.
we checked the response rate of each prefectures in Japan. They are all equal, no significant difference between the prefectures.
Okay. Thank you.
Thank you.
Miho, I see that you have another question.
Yes, I have a question. So in your survey, did you also look for how many patients were infected in each facilities and if they have experienced clusters of infection, or did you check into which preventive measures were most was associated with the prevention of infection?
Thank you for the question. We also investigated the number of facilities where nosocomial infection cluster in hospitals occurred. And in the first survey, only 4% of facilities experienced nosocomial infection. And in the follow-up survey, about 32% of facilities experienced the nosocomial infection, and the size of cluster is bigger in the second survey. And your second question about what is the most important prevention measure to prevent nosocomial infection. But unfortunately, in between the facilities who were experienced nosocomial infection and not experienced nosocomial infection, there are no significant difference of implementations on rates of prevention measures. So I have no data about this.
Thank you.
Thank you.
Just a small detail, if I may, the masks you were wearing on dialysis, you are wearing on dialysis, is it surgical masks or FFP2 masks?
Wearing of masks, we mean surgical masks.
Okay. Okay, because in our experience in Europe, we also ask our dialysis patients to wear the masks during 4 hours of dialysis, but patients do find it very difficult. So, and I can imagine that a surgical mask is already a little bit more easy than an FFP2 mask. So, but it's also surgical mask. Okay.
Thank you.
And what do the Japanese patients think of it? Is it difficult for them, or to wear the masks during 4 hours?
Almost all of the patients can wear surgical masks, but some of the patients not appropriate location of mask.
Yeah, beneath the nose, yes.
Yeah.
Okay. I think we have time for one more question. Marcia, I see that you have a question. No problem.
I wondered, based on the results of your study, do you have recommendations for your dialysis centers in Japan to how to implement or how to use preventive measures in any case of upcoming infectious diseases?
Thank you for your question. The Japanese guideline is intended to cover general infection control, such as droplet infection and blood infection, hepatitis B virus or hepatitis C virus or something like that. So we recommend Japanese facilities to implement the prevention measures written in the Japanese guideline.
I think for the sake of time, we will move on with the next session about transplantation. So now we leave COVID-19 behind and we move on to transplantation.
Okay.
My colleague will introduce Dr. Ko.
Okay, let me introduce our next speaker, Dr. Marcia Ko. Dr. Ko graduated from University of Maastricht, trained in nephrology in the Erasmus University Medical Center based in Rotterdam. And she is a research staff member in the Department of Internal Medicine, Erasmus Transplant Institute, Erasmus Medical Center, Rotterdam. And her clinical research interests is around the LECOVAC renal patients COVID-19 vaccination consortium studies on immune response registration antibody repeated vaccine. Her title of today's talk is Coping with the Threat of COVID-19 in Transplant Recipients, Insight from the LECOVAC consortium. Dr. Ko, please.
He is a nephrologist at the Mariana University School of Medicine, and he graduated from the same university. He was the winner of one of the ERA-EDTA grants. In that time, it was ERA-EDTA for the best abstracts regarding the functional stages in hemodialysis patients. But now he will tell us everything on the current trend of kidney transplantation in Japan. Welcome, Professor Chazawa.
Thank you for your introduction. So good morning and good evening, everyone. I'm Masahiko Yazawa from St. Mariana University School of Medicine, Japan. I'm really honored to be here today, and thank you so much for giving me a great opportunity to present the current trend of kidney transplantation in Japan. So aside from COVID-19, I'm going to talk about another pandemic problem, aging. So I have nothing to disclose. So I worked with Dr. Ursulia Sepulcro, chair-elect of YNP ERA in Memphis, Tennessee, as a postdoctoral fellow in 2019. So our boss is Dr. Molnar. So he is originally from Hungary, working at the University of Utah as a professor and director of the transplant program right now. So this was a wonderful time in my life. So this is the content of my presentation. At first, I'm going to show you the overview of kidney transplantation in Japan. Then I have to talk about the aging of the ESKD industry, especially the Japanese trend is very crucial. Lastly, I'm going to talk about evidence of elderly kidney transplantation. So here is the prevalence of treated patients with ESKD in each country, expressed as per million persons. As you can see on the left side, so Japan is in the 4th place, followed by the other Asian countries and European countries. So some detailed information regarding the Japanese dialysis therapy are here. So we have 38,000 patients initiated dialysis annually, and 350,000 patients are prevalent at the end of the year. So eventually, so one in 340 persons gets dialysis therapy in Japan. So this table and the figure shows the total number of kidney transplantation in each year in Japan. As you can see on the bottom figure, so we have almost 2,000 kidney transplant procedures annually. So due to COVID pandemic, the number of kidney transplantation has been decreasing in the past 2 years from 2,000 to 1,700. But it would return and overcome this situation in 2022. How to think about 2,000 procedures per year in Japan is either large or small. So this figure shows the number of kidney transplantation per 1,000 dialysis patients. So Japan is here, and only 5 kidney transplantation per 1,000 dialysis patients annually. Although 2,000 procedures itself might be a large number, kidney transplantation is still minor as a treatment modality of ESKD in Japan. Furthermore, I would like to emphasize that the proportion of living kidney transplantation is too much in Japan. As you can see in the red square, living kidney transplantation accounts for 90% of all kidney transplantation. And this trend is becoming pronounced during the COVID-19 pandemic due to decreasing the recovered organs. And waiting time is also a distinctive point in Japan. So our waiting time is approximately 15 years. Why it takes so long time to get diseased kidneys? The reasons are the organ transplant law was issued in 1997 and amended in 2011. So it's relatively brand new. And we have a non-opt-out system, which is contrary to the European system, or religious beliefs and public apathy. So I think this might be the biggest problem. And the other is excessive effort required from surgeons without any reward. Anyway, we have to wait 15 years to perform diseased kidney transplantation, except for children who can get diseased kidneys within 3 years due to the higher priority. So let's move to the other point I want to emphasize today. So the insurance-covered treatment options differ from country to country. So in terms of treatment or desensitization for rejection, we cannot use ATG as an induction therapy, while we can use it as a treatment for TCMR. IVIG was used for the desensitization pre-transplantation since 2019, while we cannot use it for treatment of AMR post-kidney transplantation. Only 2 years ago, plasmapheresis for treatment AMR post-transplantation was accepted as official use under insurance. So in spite of limited treatment options, allograft survival in Japan is relatively better than that in Western countries. For example, 1 year and 5 year allograft survival in Japan are 99% and 93% respectively. Especially over the 5 year allograft survival in Japan is better than that in Western countries. For example, US is almost 85% and Europe is almost 86% in 5 year allograft survival. So next is main topic today, aging in ESKD field. So here is a cherry blossom, beautiful cherry blossom. We can see it from end of March to April across Japan. The life expectancy of cherry blossom is almost 60 to 70 years. The average life expectancy of Japanese is 81 in male and 87 in female. So we have entered a super aged society. The incident age of dialysis therapy in the world is wide variety. So for example, UK has been falling its incident age. France and Italy are stable. The rising group includes Japan and Belgium. So Japan has already reached the incident age of 70 years. And you might be surprised, percentage of those above 80s are almost 30%, which is doubled in the past 15 years. Nowadays, 1/3 of incident dialysis patients are aged over 80 years in Japan. It's a surprising number. How does this aging trend affect real clinical outcome? We previously published a negative aspect of the aging trend of ESKD in Japan using a national registry dataset. So you might know, so even though Japan is the most excellent survivor in dialysis patients in the world, that's not always the case in the very elderly. So this figure shows crude mortality and risk ratio of death within 3 months after initiation of dialysis, based on each age categories and physical function deterioration. In patients with aged over 80s and severe disability group, 37% of the patients died within 3 months after initiation of HD. So how about aging of kidney transplantation in Japan? This figure shows the proportion of age categories from 2006 to 2020 in Japan. Although the average age of recipients are now 15 years old, recipient age over 60s have been gradually increasing. Nowadays, 30% of recipients are aged over 60. In particular, recipients aged over 70s have grown sixfold in past 15 years. This trend is comparable with US trend. The proportion of the younger age category has been decreasing, while that of the elderly age category has been increasing. Recipient aged over 75 years old accounts for 2.2% of all kidney transplantation. So how about Europe? In terms of very old age, such as aged over 75 years old, EDTA registry also shown that the substantial numbers of kidney transplantation was performed for those who were aged over 75. So the rate was almost 5%. So lastly, I'm going to talk about the outcomes of elderly kidney transplantation. So do we have the age threshold to perform kidney transplantation? The answer is no. KDIGO as well as Japanese guidelines have no recommendation regarding the age limit of transplant candidates. However, we need more information on whether transplantation in elderly is safe or not. To evaluate the efficacy of kidney transplantation for elderly patients with ESKD, I introduced some evidence-based data compared with two comparisons, either younger transplant recipients or elderly HD patients. At first, comparing to the younger recipients from UK registry, patient survival is significantly better in younger recipient compared to older recipient. So this really makes sense. On the other hand, death-censored graft survival in all age categories are completely the same. So considering life expectancy, kidney transplantation is acceptable for elderly recipients with regard to the allograft survival. Next is elderly kidney transplant recipients versus elderly HD patients. To investigate this clinical question, we conducted a systematic review and meta-analysis as a part of CKD Clinical Guideline 2023 by JSN. The clinical question is that, is kidney transplantation recommended in elderly patients with ESKD? The target population are elderly patients with ESKD aged over 65 years old. Exposure was kidney transplantation, and the comparison was continuation or initiation of dialysis. We really wanted to evaluate several outcomes, including mortality, QOL, CVD, malignancy, and so on. However, we could evaluate only mortality for meta-analysis. As you can see here, from 3,116 articles, we finally include 7 articles that fulfilled our inclusion criteria. So this is a summary table of extracted 7 articles. All of them are retrospective cohort studies, except one study investigating QOL, and from Western countries and compared to the all hemodialysis patients. Most of them used hemodialysis patient on the waiting list as a comparison who was suspected of having a better survival rather than dialysis patients not on the waiting list. So we could integrate 4 articles, only 4 articles, since they had adjusted hazard ratio as outcomes for mortalities. According to the meta-analysis, kidney transplantation for elderly patients with ESKD has significantly better survival compared to elderly patients on dialysis. Hazard ratio was 0.52. So only the patient aged over 70 years old we can integrate the 3 articles. Kidney transplantation is still significantly better for mortality compared to dialysis. So here is a subgroup analysis. One study not showing a statistically significant difference for mortality, separated, investigated adjusted hazard ratio for mortality before and after 21st centuries. Of note, the mortality of the recent era in elderly kidney transplant recipient was superior to that in dialysis patient. Based on the main analysis and this kind of subgroup analysis are consistent with the same trend. Thus, our recommendation is kidney transplantation should be recommended even for elderly patients with ESKD. Of course, these data were all from observational study and not RCT. The risk of bias was high enough not to strongly recommend it for all elderly patients. That's our official recommendation. Although any observational data indicate better survival in elderly kidney transplant recipient, but we always confront postoperative early death due to surgical invasion. This figure shows the relative risk of death throughout the post-transplant period. Relative risk of death in kidney transplant group is higher than that in continuing dialysis group only in the first 125 days. However, significantly better in kidney group thereafter. Post-operative early death is one of the biggest concerns. Thus, we should pay more attention to the evaluation and follow-up of the candidates such as cardiac function, malnutrition, or frailty. So recently, sarcopenia and frailty have been shedding light on even in the transplant field. This study investigates post-operative mortality according to the frailty score, which is commonly used in the daily clinical practice, a frailty phenotype. As you can see on the Kaplan-Meier curve, red line, which was defined as frailty, so the score greater than 3 points, suddenly drops soon after kidney transplantation, especially 2 or 3 months. So basically, any elderly patient was strongly associated with frailty, and of course, elderly patient with ESKD are super at-risk population for frailty. One of the solutions to avoid early death after kidney transplantation might be the management of pre-transplant frailty, or nutrition intervention, rehabilitation, and so on. In summary, Japanese kidney transplantation scenario has been developed via a unique trend, so mainly due to shortage of deceased donors. Most countries have encountered the aging of kidney transplant recipients as well as dialysis patients. The efficacy and the safety of kidney transplantation for elderly recipients have been established recently, but early death after kidney transplantation as well as initiation of dialysis must be prevented. We further investigate patient-reported outcomes such as health-related QOL, fatigue, caregiver burden in elderly kidney transplant recipient to set a standard of care. So finally, I would like to thank all of the members of transplant team in St. Marina University School of Medicine for any dedicated patient care on the daily clinical service and research. Thank you for your attention.
Thank you very much, Dr. Yazawa, for this interesting and beautiful presentation. I don't see any questions from the floor again, so it's been late already in Japan, I think. I don't know. I do have a couple of questions, so if I may, if no questions from the panel. My first one would be, I'm very intrigued by the fact that you do have a lot of living donors in Japan.
Yes, exactly.
How do you organize the workup of the living donor advocates? Because in Belgium, it takes like on average 6 months before we can give green light to a potential donor to be a donor effectively. How do you do this in Japan?
Yes, so we typically evaluate the living donor. So based on the KDIGO clinical guideline or Japanese clinical guideline. So the time course of transplantation is depending on the facility. So based on our facility experience, so the typically 3 or 6 months it takes to get the transplantation about 3 to 6 months. So including a cardiac health check and kidney function test, urinary test, malignancy test, and a psychosocial program asking to the psychotherapeutic doctors. So I think it's a very typical process.
Okay, you don't have a maximal age for transplantation, but do you have a maximal age for a donor?
Yeah, so it's very important question. So based on the literature, so I would say 75 years old of recipient age is evidence-based age. But so in my
wow.
Based on my experience, and some facilities try to undergo transplantation aged over 80s in Japan. So it depends on the frailty, cognitive impairment, and the physical function of the patient.
Okay, thank you. And just out of interest, do you give lower doses of immunosuppression in the elder recipients?
Yeah. So most facilities do that. So to avoid the infection or metabolic complication, especially
so from the beginning, you lower the
it depends on the it depends on the situation, and it differs from facility to facility. Okay. So based on my experience, so I use immunosuppressive medication at standard dose at first, then so decrease gradually.
Okay. In the meantime, I see that there is 2 questions from the audience. So we don't have any names, but it's an interesting question. The first one is, why is allograft survival in the Japanese kidney transplant recipients better than the other countries?
Yes, so yeah, so I have an exact evidence-based comment, but so we have a very good, super good healthcare or insurance system. For example, no one has to pay for any medication associated with transplantation, including immunosuppressive medication, any medical expense payment, as long as recipients have a functioning graft. And so, you know, Japanese recipients are typically diligent. So this is very important. So the adherence of medication and keeping good health, including the measurement of blood pressure, body weight, and the body temperature. So every day, so based on my experience, 95% of my patients completely do that, measurement of blood pressure, body weight every day. And so in terms of immunological risk, sensitized candidate is very rare because low prevalence of blood transfusion during CKD and ESKD care, a small number of second transplantation in Japan. So that's the reason.
Okay, thank you. The second question is about age again, and I think you already partly answered. So the question is, how old can we recommend performing kidney transplantation for elderly? So what would be your recommendation?
Yeah, until 80s.
80s, okay.
Yeah.
Okay, thank you. Other questions from the panelists? None? Okay. Then for the sake of time, we have to move on with the last presentation.
Thank you for having me.
Thank you.
So Dr. Cole, please, could you please start your presentation?
Yes, I will help you.
Thank you. Thank you very much.
Can you see the screen?
Yes, I can see it. Can you hear me?
We do hear you, yes.
Okay. Thank you for the opportunity to present here. I'm presenting on behalf of the RECOVAC Consortium, which is a consortium of renal patients COVID-19 vaccination with collaboration of all university medical centers in the Netherlands. We started in January 2021 and collaborate with many others such as the ERACODA registry, Dutch registries, Dutch other hospitals, and the National Institute for Public Health and Environment. Next slide, please. We performed a number of studies. The first one we started was the RECOVAC immune response study, performed in 4 academic centers, and we included healthy controls, patients with chronic kidney disease, stage 4 to 5, dialysis patients, and kidney transplant recipients. Vaccinations at the time of start, the regional of the scheme in the Netherlands, the basic series of the vaccinations consisted of 2 vaccinations, and we wanted to assess the immune response and the safety in our patients. So we had a study endpoint at 1 month after the second vaccination. And please click further. And I will show you the results. So the percentage of responders reaching IgG anti-SPAG1 antigen level was, if you click further, 100% in the control group, 100% in the CKD group, 99% in the dialysis group, and only 57% in the kidney transplant group. Next click. And you can see that the antibody levels were also significantly lower in the kidney transplant groups. We had a level of 10 as a threshold for seropositivity. But you can also see that in the dialysis patients, although the percentage of responders was high, the antibody levels were lower than in the CKD and control groups. Next click. Next one. Yes. And we also measured T-cell responses by ELISpot and by IGRA test. Here you see the ELISpot results, which are also significantly lower in the kidney transplant recipients and the dialysis patients compared to the control and CKD patients. Next click. There was a significant correlation between the antibody levels and the T-cell response, which you can see in the controls. Next click. And in the CKD patients and in the dialysis patients, no problem. However, in the kidney transplant recipients, the association was not as well defined. And you can see that there are patients who did not have significantly measurable antibody levels, but did have T-cell responses, and the other way around. If we looked at the factors which were associated with a non-zero response, so non-responding after vaccination in the kidney transplant recipients, next click, you can see that the groups which had the least response were the groups using mycophenolate mofetil or mycophenolic acid. Next click. Next click. And that was the other factors were older age, lower lymphocyte count, and lower eGFR. But the effect of mycophenolate was pronounced. Next click, please. When we wondered how the long-term effect would be. Next click. So we had a second study point at 6 months after the second vaccination. And we performed again tests of antibody levels. And as you can see here, next click, is that in all the groups there was an equal rate of antibody decline. So the kidney transplant recipients did have lower responses and lower levels, but the rate of decline was similar to the other groups. Next click, please. Next click. And so you can see that when extrapolated, the groups would lose their antibody levels in this time period. And the lower you start, the sooner you have lost, of course. Next click. So the consequences for our kidney patients were from the results of our studies that the National government decided to add a standard third vaccination to the basic series of vaccination in these three groups. So kidney transplant recipients, dialysis patients, and CKD stage 4 to 5 patients who used immunosuppression, and it was meant to increase immunogenicity. But we wondered whether repeated COVID vaccination would be efficient in these patients, or that other vaccination strategies might be more efficient. Next, please. At the meantime, we conducted another study in the Netherlands, the antibody study, and we approached CKD 4/5 dialysis and kidney transplant patients in large numbers by a letter and by phone and by communication in their treating facilities, and asked them whether they could do a finger prick to draw blood at home and to send the blood sample by mail to our investigators. And as you can see, a lot of kidney transplant recipients responded, somewhat less dialysis patients and still less CKD patients sent a sample at 1 month after their second vaccination. And later on, they also sent a sample after the third vaccination. At both times, they also send in COVID-19 questionnaires. Next click. Next click. And after analyzing all those results, we found that not only seropositivity, but also the antibody level, so the height of the antibody level, was correlated with the incidence of COVID-19 and the severity of COVID-19. Next click, please. So higher antibody levels should be aimed for, not only reaching seropositivity. Next click, please. We also published part of the antibody study on the impact of immunosuppressive treatment in a subset of the patients. And here you can see in summary that the use of immunosuppression in all patient groups significantly lowered seroresponse rate. And the use of CellCept, so mycophenolate mofetil or mycophenolic acid, in kidney transplant recipients had a pronounced effect. Next slide, please. So we wondered, how can we overcome this low response in kidney transplant recipients? And we performed the next study, the repeated vaccination study, again in 4 centers in adult kidney transplant recipients who did not seroconvert after the second or third dose of an mRNA vaccine. And we divided them in 2 cohorts in which they were randomized in cohort A to either receive a standard single dose mRNA vaccine or a double dose of the same mRNA vaccine simultaneously in both upper arms, or heterologous vaccination with a virus vector vaccine. And in cohort B, consisting of patients who were on triple immunosuppression, they were randomized either to continuate mycophenolate mofetil or discontinuate it during 1 week before and 1 week after vaccination. The primary endpoint was the percentage of seroconversion 1 month after vaccination. Next slide, please. And the most important results were that a repeated vaccination does increase seropositivity rate. So with every repeat vaccination, you can reach more seropositivity in more patients. However, there was no benefit of a double dose or heterologous vaccination or temporarily discontinuing mycophenolate mofetil in the response rate. Importantly, next click, there were no episodes of graft rejection in the mycophenolate discontinuation group. Next slide, please. So to conclude this, we saw lower immunogenicity of COVID-19 vaccination in patients using immunosuppression, leading to repeated vaccination in our country. Especially the use of mycophenolate mycophenolate mofetil or mycophenolic acid was associated with low antibody response. The risk of getting COVID-19 or getting severe COVID-19 was associated with the antibody response, but also the height of the antibody level. And repeated vaccination does increase antibody response, but we found no benefit of a higher dose or heterologous vaccination or interruption of mycophenolate mofetil. So for the future, next slide, we wondered whether replacement of mycophenolate mofetil by everolimus, an mTOR inhibitor, would improve our results. From the OPTIMIZE study, which is a study in new kidney transplant recipients older than 65 who were randomized to receive CNI, MMF, or prednisolone, or a lower dose CNI with everolimus and prednisolone. Next click. We saw that in a few patients, there was a higher antibody response to mRNA COVID-19 vaccinations. So our goal for the future, yes, please, is to perform a new study, next click, in a prospective randomized trial in adult kidney transplant patients on at least dual immunosuppressive therapy, including MMF and the CNI, next click, in which we want to randomize between continuing MMF or switch to everolimus, and 6 weeks afterwards perform a COVID-19 vaccination with the bivalent mRNA vaccine, and then assess immunogenicity after 1 month. And if patients are willing, they can also continue the study and receive herpes zoster vaccination with a recombinant zoster vaccine, and then also we assess the immunogenicity of that vaccine. Next slide. This is supported by and designed in collaboration with the Dutch Kidney Patient Association. Next slide, please. I want to thank on behalf of the RICOVAC consortium all collaborators of ERA-CODA. And next slide. Also our patients and sponsors and all study investigators. Thank you for your attention.
Actually, we have seen a cluster of cases of new onset glomerulonephritis, especially ANCA vasculitis, right after the vaccination. Did you collect any data of graft rejection and also the relapse of original glomerulonephritis in the kidney recipients?
Yes, we did. We did that in the first study we performed, so the immune response study, and also in the repeated vaccination study. But we did not see acute rejections in the study period, and also no recurrence or exacerbations of autoimmune diseases after vaccine.
Thank you. And Dr. Seplikal, I hope I'm correctly
Yes.
pronouncing your name.
Yes, you're correct. Thank you very much. So first of all, I'd like to congratulate for the whole session, because both presentations were like exceptional and impressive also. So I don't know. I'm just asking from the chairs, chairs of the sessions, if I might ask 2 questions, one for Masahiko and one for the second presentation. Is it possible?
Sure.
Yeah. So first of all, congratulations, Masahiko, and thank you very much for your presentation. So, and I was just wondering on your opinion and on your clinical practice regarding the vaccination protocols against COVID among patients on waiting list, kidney transplant waiting list. And after that, I also congratulate for the second presentation. So those were just really very impressive data and results. And I also was just was just thinking about that so nowadays most of the transplant centers have the protocol for vaccinating against COVID, which is mandatory on a kidney transplant patient on waiting list. But what would be the future? So I would like just to ask for your opinion on the basis of the latest clinical data. Thank you very much.
Okay.
First, Dr. Yazawa, please. Yes.
Yes. Thank you for asking, Soria, and long time no see. And so according to the Japanese guideline for the waiting list of recipient candidate, so we strongly recommend the full dose vaccination before and after also transplantation. So such as 4 times or 5 times vaccination we need. So we strongly recommend it.
And Dr. Ko, could you please answer the question for you?
Yes, I agree. In the Netherlands, there have also been 5, sometimes 6 vaccinations for immunosuppressed patients, immunocompromised patients, and we also strongly advise our patients to receive all vaccinations that are possible, preferably before they start immunosuppression. But it's not mandatory, so if patients do refuse, we don't refuse them a kidney transplant, but we try to explain why it's better, why they are better protected when they have all the vaccinations beforehand.
Thank you very much.
I think it's about time. And if you have questions, maybe we can communicate later on. And thank you so much for all the speakers and the audience for joining us today. And we want to close this session today.
My name is Ivan Riklik. I already have been introduced. I'm serving as a Secretary Treasurer of ERA. And just to say a few words in the end of this very nice session, I would like to appreciate all speakers because really the presentations were very interesting and I learned a lot and I was very happy to hear about that. Anyway, I would like to stress that there is a long cooperation between Japanese Society of Nephrology and between ERA. So I am very happy to see that this cooperation is even increasing. And what I think is the most important, and the young generation is involved. And I feel that this is the future of both our societies, that this cooperation should be supported and we should even do or organize these meetings regularly, let's say once, twice a year. So again, I would like to thank to all participants. It was a very nice event and fingers crossed for future. Thank you very much.
First of all, I'd like to thank the chairpersons, Amaryllis and Miho, for moderating sessions. And I would also like to thank the speakers, Tobias, Yuka, Masahiko, and Marcia, for giving outstanding talks. Of course, this meeting had not been possible without the great support and leadership by Christoph Werner, Ivan, and Motoko. So I really thank them. This is a wonderful opportunity for young nephrologists. Japan won the World Baseball Classic yesterday, and Shohei Ohtani, the great player, said before the game, let's stop admiring the people. If you admire them, you cannot surpass them. And young nephrologists are here to surpass the old great people. Motoko is the one who has already surpassed many great Japanese nephrologists. And you young nephrologists in Japan and Europe will soon surpass us. So I am very excited to hear great talks by you, and I'm looking forward to be surpassed very soon. Thank you.